This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, a senior attending here, and it is a pleasure to have you with us for another deep dive into the latest literature.
And I'm Dr. Elara, research fellow. Today we're looking at a fascinating new study from the journal Clinical Neurology and Neurosurgery, set to be published in 2026. The paper is titled Prior Surgical Resection is a Predictor of Facial Nerve Function Decrement After Radiosurgery for Vestibular Schwannomas.
This is a critical topic, Elara. As we know, gamma knife radiosurgery, or GKRS, is a standard treatment for vestibular schwannomas, whether it's used as an upfront primary treatment or as an adjunctive therapy for residual or recurrent tumors after a surgical resection.
Exactly. While we often think of GKRS as a salvage or secondary option, the paper points out that it's actually poorly understood whether that prior surgical intervention influences the risk of facial nerve injury once the patient undergoes GKRS. The authors wanted to see if the scarring or the altered anatomy from a subtotal resection makes the nerve more vulnerable to radiation.
So let's talk about the study design. This was a retrospective analysis of 395 patients, correct?
That's right. They compared two distinct cohorts, the upfront group, which consisted of 354 patients who received GKRS as their primary treatment, and the post-surgical group, which had 41 patients who received GKRS after a surgical resection.
Those are substantial numbers for a single-center analysis. Now, the primary outcome they were looking at was facial nerve function, which they measured using the House-Brackman scale. What did the data show?
This is the most significant finding of the study. They looked at the 5-year rate of stable or improved House-Brackman scores. For the patients who had upfront GKRS, no prior surgery, the rate was an impressive 99%. However, for the post-surgical group, that rate dropped to 88%.
That's a statistically significant difference. I see the p-value was 0.01. For a neurosurgeon counseling a patient after a subtotal resection, that 11% difference is something we need to be discussing. Did they perform a multivariate analysis to see if prior surgery was an independent predictor?
They did. Prior surgical resection was identified as a significant predictor of facial nerve function decrement. In fact, the hazard ratio was 6.8 with a p-value of 0.01.
A hazard ratio of 6.8 is quite striking. It suggests that patients who have already been under the knife are nearly 7 times more likely to experience a decline in facial nerve function following radiosurgery compared to those who are radiation naive. Why do we think that is?
The paper suggests that prior surgical manipulation might leave the facial nerve more susceptible to the effects of radiation, perhaps due to compromised microvascular supply or mechanical stress during the initial resection.
That makes clinical sense. Now, what about the other cranial nerves? Did the study look at trigeminal nerve function or hearing preservation?
Yes, they looked at both. Interestingly, the results weren't as divergent there. For trigeminal nerve function, the 5-year rate of stable or improved function was 98% in the upfront group and 94% in the post-surgical group. The p-value there was 0.17, so it didn't reach statistical significance.
And hearing? Most of our residents are always concerned about the Gardner-Robertson scale outcomes.
The Gardner-Robertson scale was used to assess hearing. The 5-year rate of stable or improved hearing was 82% for the upfront group and 71% for the post-surgical group. Again, the p-value was 0.36, so while there was a numerical trend towards worse hearing in the post-surgical group, it wasn't statistically significant in this cohort.
So the heavy hitter here is really the facial nerve. But what about the actual efficacy of the GKRS? If we are seeing more facial nerve morbidity in the post-surgical group, are we at least getting the same level of tumor control?
That's a great question. The study found that tumor control was virtually identical. The 5-year tumor control rate was 95% for the upfront group and 94% for the post-surgical group. The p-value there was 0.69.
That's an important takeaway for our residents. The biological control of the tumor with gamma knife seems to be independent of whether the tumor has been debulked or not. The radiation works just as well to stop the growth, but the functional cost to the facial nerve is higher if the patient had prior surgery.
Exactly. To summarize the paper's conclusion, prior surgical resection is a significant predictor of facial nerve function decrement, but it doesn't seem to significantly impact tumor control or the preservation of trigeminal and hearing function when compared to upfront treatment.
This really underscores the importance of the first shot in vestibular schwannoma management. When we decide on a subtotal resection to protect the nerve, we have to be aware that the subsequent adjunctive radiosurgery carries a slightly higher risk profile for that same nerve than if we had used radiosurgery from the start.
It definitely adds a layer of nuance to the multidisciplinary consultation.
Well, this has been a very productive discussion. Thank you, Dr. Elara, for bringing this 2026 study to our attention. It's clear that while GKRS remains a safe and effective tool post-surgery, we need to be more precise in our prognostic counseling regarding facial nerve outcomes.
Thank you, Dr. Aris.
And thank you to our listeners. Join us next time on the Neurosurgery Hub Podcast for more updates from the frontier of clinical research. Stay sharp.